7:45 in the morning. It is a quarter away from 8 o'clock. It is the voice of Indiana County, WCCS 101.1 FM, AM 1160, and what has begun as a very, very pretty day. Sun is shining out there. AccuWeather says we're on the way today to 52 degrees. Dr. Dan Clark is with us once more, and our conversation is brought to you by Marcus & Mack, voted best personal injury law firm in the Best of Indiana County contest. Marcus & Mack, a law firm representing injured people. This is coming up on the very end of Colorectal Cancer Awareness Month, and every year we visit this topic and do so in a series of morning conversations. Dr. Clark is always a big part of that, and there's a reason for that too. I don't know that there's all that much that we have not covered, but it's really worth pressing the issue because this is such a common cancer.
Right. You know, my chief in my residency program always said that repetition is the hallmark of adult education. And I think with colorectal cancer being so common and so preventative, that it's a good idea to go back over the recommendations and what we need to do about it.
Yeah. Okay. So what are some of the things that we really need to emphasize today?
Well, the main thing is that, like we've talked about, is that we're seeing colorectal cancer in younger and younger people out there now. The death rate for people over 50 has decreased dramatically in colorectal cancer, but the death rate for people under 50 is increasing. And that's a scary thought. And, you know, it's just like breast cancer. We're seeing younger and younger women with breast cancer as well. And, you know, there's a lot of theories as to why that is. But as a result of the younger people getting colon cancer, the American Cancer Society decreased the age at which they recommend screening. You know, and now instead of being age 50 when you should have your initial colonoscopy, it's age 45. You know, and that word really needs to get out there. You need to get a colonoscopy. You know, I listened to Dr. Billen last week and how he talked about how this, you know, the best surgery for colon cancer is no surgery.
Yeah.
And that's the truth, you know, because it's completely preventable if we get screening done at the appropriate times.
Yeah, we've talked about the subject from a number of different angles. The last time you were here, we were talking about genetics and the various factors that are involved in people coming up with colon cancer. Lifestyle has a lot to do with it, what you're putting into your body. I think Dr. Billen pointed that out as well. The types of foods that we're eating and the various things that we do with our lives. Right,
and you know, there's a lot of things like everything. Being overweight increases your risk of a lot of cancers, including colon and rectal cancer. You know, it increases your risk of breast cancer as well. You know, there's a lot of data to say just an active lifestyle will decrease your risk of colon cancer. Mm-hmm. And, you know, he's a big proponent of the Mediterranean diet. And there's a lot of data coming out now that shows that does decrease your risk of colon and rectal cancer as well. Yeah. So keeping away from the high-fat foods, you know, processed foods, lunch meats, you know, things like that. Nitrates have a lot to do with it. Hot dogs, you know, we briefly touched on those in the past, but, you know, staying away from the processed foods, staying away from the high fats, and avoiding a lot of red meat. You know, I like a steak myself, you know, and hamburgers and everything else, but you shouldn't be eating those every day of the week. You should modify your diet. Get some fish in there and some pork and some chicken, you know, mix it up a bit.
Yeah, yeah. Man, here comes baseball season, though. I got to have my hot dogs.
That's right.
I need my hot dogs, and I need to go to the Altoona Curve game and get myself a Curve burger. But you're right. It's not that those things are poison and that we have to avoid them altogether, but we have to be sensible.
Right. We shouldn't be eating red meats and processed meats every day of the week.
Yeah. You know. Okay. So you get the screening, and the polyps are there. The polyps are removed. The risk of cancer is not only greatly reduced, it's practically nil now, correct?
Right. If you get a cancer out before it has a chance to turn into, or get a polyp out before it has a chance to turn into a cancer, you don't have cancer. You know, it's that simple. Mm-hmm. Now, the main thing is that you don't stop there. If you have a colonoscopy at age 45, average risk people, and it's negative, no polyps or anything, you don't need another one for 10 years. But if you have a colonoscopy and they find polyps, then the recommendation is anywhere from 1 to 3 years in the future, you need to have another colonoscopy depending on the number of polyps and the type of polyp that was found and things like that. So continued screening is necessary if they do find polyps. The data also shows that if you have polyps, you have about a 30% chance of forming additional polyps. And that's why the more frequent colonoscopies are recommended in that situation.
Now, if it's gotten to the stage where cancer is actually a part of what we're talking about, the polyp has developed into cancer, so now you have it, then what happens?
Well, at that point, the best treatment is usually surgery. We do an evaluation to see if it's spread. CAT scans, sometimes CT, or sometimes PET scans, sometimes MRIs. We do blood workup and things like that. If it's isolated to the colon, the best treatment for that is surgery, and getting that section of the colon removed, along with the lymph nodes that drain it, so we can evaluate the lymph nodes to make sure there is no spread.
Mm-hmm. Yeah, so that has to happen. And the methods by which the surgeries are performed, you, of course, heading up the robotic surgery department at IRMC, they are so much better for treating this kind of cancer. Really, when it comes to robotic surgery, if that's an option for you, it's better than any other kind of surgery. It doesn't matter the type, but particularly when we're talking about colon cancer, it's a great advantage, isn't it?
It's far superior to any other technique we've ever had. The open surgery, you would be in the hospital for 10 to 14 days, have a large incision, fair amount of pain. It would be tough to recover from that operation. On top of that, if you were unfortunate enough that there were some disease in the lymph nodes and you needed further treatment beyond surgery, we couldn't give you that treatment until you recovered from that operation. Now with robotic surgery, we have 4 small incisions. You get out of the hospital. Some of my patients go home the next day. On average, it's 2 days in the hospital. Most patients don't require narcotics because we do nerve blocks at the time of surgery. It's not just the robotics, but some of the different techniques we use in addition. We do long-acting local anesthetic nerve blocks around the incisions in the operating room, which you wake up with dramatically less pain even in those small incisions. So you're up out of bed immediately. Dr. Billen talked about our early recovery programs. They're called ERAS, Early Recovery After Surgery. I've been using those since before they ever had the fancy name. It's been in the literature for over 20 years. I've been doing colon and rectal surgery for almost 30 years now. And before anybody termed that or coined that term, the data was coming out that getting people up out of bed immediately, early feeding actually stimulates GI recovery. We used to wait till you had a bowel movement before you were fed. Sometimes that would take 3, 4, 5 days. And then we did a slow advance of your diet. You would get clear liquids for a day, then full liquids for a day, then a soft diet for a day, and then a regular diet for a day. There's 4 days in the hospital. We now know that that was not based on physiology. That was just based on that was the way we always did it. When we're operating on your colon, we're at the other end of your intestines from your stomach does not get affected by the surgery. It works right away. And when food comes out of your stomach, it's a chyme, it's a sludge that comes out of your stomach because your stomach is your trash compactor of your body. Mixes it all up with the digestive enzymes and the acid and breaks everything down. So what you put on your mouth really has little to do with how it hits your colon. By the time it gets to your colon, it's liquid. So the only reason to give you clear liquids after colon surgery is to make sure you're not nauseated from the anesthesia or the surgery. Make sure you don't feel bloated. But if you can tolerate a clear liquid diet, you can tolerate regular food. And so we no longer do that 4-day diet advance. It's clear liquid diets and pretty much go in the regular diet. And that's why if we do the surgery on a Monday morning, which my main block for these type of operations is Monday, if I'm doing the colon surgery on Monday morning, you're on clear liquids Monday night, and then probably on a regular diet the next day. And that's why some people even can go home at 1 day, after surgery rather than 2 weeks. And people are going home and not using narcotic pain medication because they have such little pain after these operations. It's amazing to me.
Yeah, it absolutely is. Okay, so for that person at home who is sitting and has been listening to these conversations here for this last month and still isn't convinced about the need for early detection and to get that colonoscopy. I know it's difficult to say to that person, what else can I say that is going to convince you to do so, but it is that important for them and for their family life.
Absolutely. Especially if you have a family history of colon cancer, the recommendations are earlier than 45, and the genetic testing that we talked about, because it can affect your kids as well. But what I can tell them, and I heard Dr. Billen touch on this a little bit last week, was that you don't want a colostomy. You don't want something that's completely preventable spreading to your liver and your lungs and killing you. And that's the reality of colon and rectal cancer. That's where it spreads. All the drainage from the colon goes to the liver. And that's why the liver is in the number one spot for spread from colon cancer. Mm-hmm. After the liver, it goes back into the bloodstream and goes up through the heart and gets filtered out into the lungs. And so that's why the lung is number 2 spot. And that's what kills you from colon cancer. And it's completely preventable. And so if you get out there, get your colonoscopy done, we can find polyps, remove them before they ever have a chance to become a colon cancer. Or, if we do find a colon cancer, we can find it very early, and we can do a robotic resection. And with lymph nodes not involved, that's all you need. You don't need anything else. You have a robotic resection. It has a low complication rate. It's a very high precision operation. Out of the hospital in 1 to 2 days, back to functioning. If you have a job that does not require any labor or physical strenuous activity, I've had people back to work in a week, after having their colon removed, which I've been doing this a long time. I've done the progress from open surgery to laparoscopic to robotics, and the recovery with robotics is so dramatically different, it amazes me to see this progression.
Got to get it done.
Absolutely.
Yeah. And a great team to do it at IRMC.
Yeah, we have one of the most experienced colorectal teams in Western PA. As you know, I was a national proctor, still am a national proctor for robotics. I travel the country teaching robotic colorectal surgery. I've taught at universities up in Boston, in Pittsburgh, in Philadelphia. I've taught at several universities around teaching chairs of colorectal surgery, how to do this operation. And I've been doing this for 14 years now. I was the first certified general colorectal robotic surgeon in Western PA. And I actually came to Indiana to teach or proctor the robotic surgery when they first started their program. But now the program's 7 years running. We have 7 years of experience just at Indiana with all of our surgeons doing robotic colorectal surgery. You won't find that, in very many places in Western PA at all.
Yeah, but you find it here at IRMC.
Absolutely.
He is Dr. Dan Clark. Convinced me. I hope you convinced a whole bunch of other folks, too.
Thank you.
Thank you and Dr. Billen and everybody else who has come in to talk about this very, very serious subject. And hopefully we have convinced a few people to get that screening done because that's what needs to happen. For those who want to do this, but they don't know where to start, what's the best thing that they should do?
The easiest way is to contact their primary care doctor, but they can easily call our office, or one of the gastroenterologists. We have Dr. Kramer at IPG who does routine colonoscopies. Our partners do routine colonoscopies as well. Most insurance companies nowadays don't require a referral, but you have to check your policy, of course, to make sure you don't require a referral. But call to your primary care doctor and saying, hey, I'm above the age where I should have this done, and they can easily make a referral.
Good job. Dr. Dan Clark, thank you so much.
Oh, you're welcome. Thanks for having me.
It is the voice of Indiana County, WCCS.